Hi, good morning, everyone. Good morning to you in person and then also to those online. The discussion that we have for the next 50 minutes is introduction of the new Guyana Research in Injury and Trauma Training GRITT program at the University of Guyana, a sister program of the Columbia University Center for Injury Science and Prevention. On the panel, we have Professor Emanuel Cummings, the Deputy Vice Chancellor. Ms. Caralord was supposed to be here, haven't seen her yet. Professor Christina Hoven is here. Prof Charles Branas online. And then Dr. Reeta Gobin is not here. And Dr. George Musa is here, and Dr. Alexandra Harvey. So I think we'll start off with Professor Emanuel Cummings in terms of what it is, for Guyana and for UG, and then we'll go along with other panelists.
Good morning, all, and thank you very much, Dr. Aduku, all fellow panelists and members in the audience. Very good morning, and sorry to be late to this came in. But certainly, I think, when we look at the project overall and what Guyana finds itself in at this time in its history, the data indicated a country that is really torn apart by trauma and injury, self-harm and injury. High rates of suicide, high violence, domestic violence, land transport accidents, which significantly decorates our statistics. And it's always my opinion that the university should always find ways and means of dealing with issues as we seek to make our nation a developed one and to take it to the next level. Notwithstanding all of our development of the oil and gas industry, which will certainly boost tourism, boost our economies, we need to have a country that persons would want to come to. And so what would this center do in terms of responding to the issues which Professor Christina outlined yesterday, which we all know of the issue of trauma and injury in our nation? And so certainly, I, as the Deputy Vice Chancellor, who have responsibility for all academic programs and research within the institution, will be very happy to host such a center that will create an opportunity for interdisciplinary research and education. I see at some point we have to decide exactly where, in which, because we have several faculties, we have colleges, the College of Medical Sciences. We have now established the College of Behavioral Sciences, which will coordinate all the behavioral sciences, sociology, psychology, psychiatry, criminology. All of that will be within the College of Behavioral Sciences. And then we have the School of Medicine, which hosts medical medicine, optometry, medical rehabilitation, all of the programs would somehow have some input with respect to how we respond to a national issue of injury prevention. And so I think it will also create an opportunity for research, for research in the area. When you look and see, we have statistics, but also we also have to look at the mitigating factors. What are the factors that may have contributed to a lot of the issues, and how do we respond the social determinants which might have contributed, and all the socioeconomic issues that might have revolve around these issues. And so I'm just throwing out some ideas there as to the center of itself, which we will have to decide. I'm just, we have the School of Medicine, we have the School of Behavioral Sciences, we have the College of Medical Sciences, which overall envelope the School of Medicine. And we also have the Faculty of Social Sciences, which I think are the three areas, and notwithstanding agriculture, because when you look at the statistics, particularly in Guyana, a lot of suicide has been related to the consumption of chemicals used in agriculture. And so all of these areas, all of these things that we have to look at, how do we develop policies on education and road safety, motor transport accidents, all of those incidents which we all know. And so what I'm trying to paint a very colorful picture as to what we have and how the university, we should be able to put all of these things together in one center that will address and make Guyana a much safer and a much more beautiful nation. Those would be and as indicated, because I have to give other panelists an opportunity to speak as well, that that I see as a university how we can host such a center and the connections and the collaborations that would involve the development of this center. Thank you very much.
Well, thank you, Professor, for your comments, for your remarks. Oh, because of the net. Sometimes I think it's okay. Well, thank you, Professor Cummings, for your remarks. We take delight in always saying that it's a pleasure working with you because you're always there. You make yourself available all the time. Thanks so much. The next speaker is Professor Christina Hoven, who is the lead for everything that we are doing here. Professor Hoven.
Thank you. Thank you very much, Professor Cummings, and thank you all for being here in person and online. This is a very exciting time for us. As I said yesterday, I see this meeting essentially as a celebratory meeting as we begin the process of addressing suicide in a multifaceted manner. And GRITT is one of those approaches. It's actually just been funded and it's just entered its second week, and we are having our first meeting this afternoon. So it's brand new, and I encourage all of you to think about how you can be involved in GRITT. We need everyone. And I also want to apologize for Professor Reeta Gobin, who is the principal investigator here. She is also the head of the medical school, and so she is unable to be here today. She has an urgent issue. So I apologize on her behalf for not being here. I just want to give a broad general outline of what we're hoping to do, and then we're going to hear from Professor Branas, who has in fact been the principal investigator of two similar studies. He's the co-director of GRITT, and he's also the director of a large similar center in New York City. So I just want to say about our center here, the primary focus, of course, is injury and trauma prevention. And that's a big, big bite when we know about all the kinds of car accidents that we've talked. And yesterday we had a wonderful talk about the extensive research that's going on here on car accidents, which is a big problem. And we hope the center is able to help move in the direction of mitigating some of that work, some of those accidents. The other issue that we talked a lot about was the domestic violence, and we've heard a lot about that. And we heard from the minister today, we heard from the minister yesterday about the problem of domestic violence. Violence in the street, that's another area that we definitely want to work on. So the purpose of the center is basically an educational arm. It's a training arm. So when I say we want to work on things like domestic violence and automobile accidents, transport accidents, what we're talking about is attracting you. You are the people who are living with these problems. And what we want to do is to train you to investigate these issues, to find ways of stopping them. The way you would stop traffic accidents in Boston is not the way you would stop traffic accidents in Georgetown. And so we have to work together to find ways to mitigate these problems. And a lot of it has to do with the need for training. There is a lot of expertise out there in transport accidents. We want to bring that to you. We want to bring to you as many opportunities as possible to be trained. We have a certificate program with Columbia University, Mailman School of Public Health. We want to bring in students, both physicians and MPH students, to join that program and to be mentored to become researchers in this area. And I will now turn to Dr. Branas, who has actual experience in running 2 of these centers and exchanging students and developing a training program. So I'll ask him to speak to that and speak to the great successes that this kind of training program can have in a country such as Guyana. So thank you very much. And remember, suicide is something we always want to look at. And this center is always thinking about how we can mitigate suicide as one of the traumas and injuries. Thank you very much.
Christina, do you want me to speak now, or can you hear me?
Yes, please. Go ahead.
Okay. So I have 3 or 4 slides. Is that something that I can show that you would also see there, or I can just speak otherwise? I'll just speak. It's fine too.
Can you please share your screen?
You want me to? Sure. Okay.
Thank you.
Thank you very much. You know, I thought I would speak a little bit about our CDC center and then talk about, can you all see this?
Yes, we do.
Brilliant.
Yes, we can.
Brilliant. Thank you. So let me just start by saying, I am honored to be here. And I want to thank the Deputy Vice Chancellor, the Dean of the Medical School, and all the folks at the University of Guyana. I mean, it just means so much for us to be able to do this. Let me start by just giving you a little bit of background. So Christina talked about GRITT, the new Guyana Research and Injury and Trauma Training program. And I have to read it myself because I haven't memorized what the acronym means quite yet. But I like GRITT. And this is connected to our Centers for Disease Control and Prevention Injury Science and Prevention Center at Columbia University. And I want to say that GRITT, the training program in Guyana, is funded by the National Institutes of Health in the United States, by the Fogarty International Center. And the I in NIH is plural. There are multiple institutes at the NIH. One of them focuses on health issues outside of the United States, and that is the one that is investing in this particular work. In a similar way, the CDC, the first C, is also plural. It is a series of different centers at the Centers for Disease Control in the US. And in fact, there are 8, I had to look it up just now, there are 8 national centers. And of course, the Centers for Disease Control focuses on things like health statistics and infectious diseases very, very much, as well as chronic diseases. But one of those centers is the National Center for Injury Prevention and Control. One of those 8 centers at the CDC, and few people know about it. The National Center for Injury Prevention and Control is the youngest of the centers at the Centers for Disease Control. And it was really only started in the early 1990s, unlike the other centers that have been around for quite some time. So one of the great things about the CDC's investment is that they do want us to focus on a number of different things, but very much they want research, but they want things that are going to have an impact in preventing injury and trauma in the United States and in the world. And I will say there are 8 such centers, like our Center for Injury Science and Prevention at Columbia. There are 8 such centers across the United States. Very few of those centers, because the primary charge of the centers is about US-based trauma and injury prevention. So very few of those centers focus outside the United States. And I will say for our center, really, you will be our primary partner outside the United States. Will be our connection to Guyana and the university. So we're very, very excited about that. The vision and the mission of the center is science in service to safety. But I want to say before I get to that, just to give you some background about how important injuries and trauma are globally. I'll tell you, I had years ago, maybe 5 or 6 years ago, I had a conversation with the Gates Foundation, which of course is very much focused on infectious diseases and the prevention of infectious diseases. And as we all know, through the pandemic, that's incredibly important. But one of the things I raised with them is that there are more people that die of injuries globally. There are about 5 million people that die of injuries globally every year. And that's more than all the deaths from HIV, malaria, and tuberculosis combined, what the Gates Foundation calls the big 3. So that was news to them. And in fact, they forced us to prove that to them. And we went and got the numbers and put that back there. But injuries are a major, if not the major health threat to children and young adults, to people before the age of 45 in the world. And they are particularly challenging for developing nations. And I want to show you, not just in disability, this is an old article from the New England Journal in 2008 that was actually written to elevate the importance of chronic diseases globally. But injuries really rise up here as something that's quite important. And there are 3 basic types of injuries, and these are the fatal versions of them: homicides, suicides, and unintentional injury deaths. And we are all tragic and something that we really need to work on globally in getting a handle on. I've done a lot of work in all 3 of these, and our center at Columbia focuses on 3. And of course, we're going to focus very heavily with you on suicides and how you might help us understand the issue in Guyana and a way forward. I also want to point out the word, and I know we all use it, and it's just fine, but injury prevention scientists don't like to use the word accident. That is something that we try to avoid, because we try to say unintentional injuries or unintentional injury deaths, or motor vehicle crashes, not motor vehicle accidents, simply because an accident, the word implies that it's not preventable, that it is somehow an act of God. And so I just wanted to point that out. It's not an issue, and the word accident will of course continue to appear, but the point that's made through that is that we really do want to use science here to prevent and to improve quality of life from these injuries. So our center's mission or vision is science in service to safety, where we want to leverage the unique connection of university, community, and government partners around strategies to impact safety and injury prevention and health ultimately. I will pass through this. We have a pretty detailed group at Columbia that includes more than the School of Public Health and the School of Medicine. We also involve the School of Engineering, Nursing, Law, journalism, social work, and so forth. And so that's something that I would welcome. Injury prevention is very much, as the Deputy Vice Chancellor was saying, is very much an interdisciplinary exercise. And so this would be at the University of Guyana. I assume that this would go well beyond the medical school. Some of our partners at our center, and I will say we have suicide as a primary goal for suicide prevention is a primary goal for our center, but there are a number of other things that we work on, including gun violence, which is a major issue for the United States, as well as opioid poisonings and adverse childhood experiences. And that's really all I have on that. Let me unshare and come back to you all. And I think we have a couple more minutes. I saw a couple hands got raised and a few questions, so I want to come back to that. And perhaps as a group, we can talk about this a little bit more. And the work that Christina was referring to, I presented a little bit more about our work on injury prevention in Central America and in Southern Africa that I had been part of in the past. And really a lot of these programs to train injury prevention specialists, our trainees, our folks that we interacted with have gone on to be leaders in their nation. And in fact, some of them were already deans of medical schools and had high-level postings in their ministries of health. But in countries like Guatemala, El Salvador, Botswana, South Africa, major challenges and great programs have emerged to prevent these sorts of major challenges. And I'm very much looking forward to us having continued conversations about what would be a way forward, particularly around suicide, but also around the other topics that were mentioned, I think, which are also quite important. Domestic violence, intimate partner violence, and motor vehicle crashes are also potentially of great interest to you all. Thanks so much for the opportunity to say something.
Thank you, Professor Branas. I think we will listen to the presenters. Then after that, we'll go to the questions together. So I'm going to call on Dr. Harvey to make her presentation.
Okay, good morning all. Thank you very much for having me on this really high-powered panel. So I'm Dr. Alexandra Harvey. I'm the Director of Medical Education at Georgetown Hospital. And I oversee the department called the Institute of Health Science Education, or IHSC. And that's the department at DrPH that deals with postgraduate education in terms of training and research. So we have been doing programs just since 2006. And just wanted to show you. So we started with just one program. We're now currently offering these 15 specialist residency programs. And these are all accredited through our affiliation with the University of Guyana. The model that we use is really that of partnerships, so that we are really happy that if we can be working with Columbia University in this GRITT initiative, because it falls in line with what we do. That we do prefer to have programs and training that can be conducted here in the main, as opposed to years ago, well, all the training was conducted overseas. People would have to go overseas and then they would come back, hopefully. And many times they did not. What we found is that because we are conducting most of our programs, the most core content locally, and together with the partners where we can get exposure in terms of technology and bringing us up to the standard, we found that in this way, more persons are more likely to stay. In fact, in most of our programs, the majority of people are still here. And so it means that we have to have local faculty, which we do. And so we look forward to having faculty development opportunities in this GRITT program. As you can see here, these are all clinical areas that we have training in. And so there's no actually research degree, these are all clinical degrees. But all of our programs do have a research component where the graduates have to produce a scholarly project in order to graduate. And then we also have, in terms of research, we through the IHSC, we have an annual research conference where persons can present their research efforts. And we also have an in-house epidemiologist now, because we are having more focus on this area of research. So that apart from these, we also have some short courses, so that overall, in terms of training and research, I think that we have the sort of setup to be working with GRITT. I think we have the infrastructure, and we really look forward to that, because we also think we have even the human resources, because over the years we've actually produced about 200 graduates, and we have 170 or so actually in training. So we have the human resources. I think we have the setup, and so I really look forward to working with this initiative, because I think we can really get somewhere. It's as if all the foundation has been laid, and it's just now for us to move forward and to expand. But what I really wanted to actually bring up here in the moving forward, let's see, move forward here. Yeah, just to go back, is it? Back. Right there. In moving forward, I think we are living in well, the times we're living in, the pandemic times. So I was just looking at, we have the foundation, we do training, we do research, we're hoping to expand and so on. But maybe we could look at some of the possible challenges that we might have doing training and research at GPHC during these times. And I'm calling the COVID times. I see persons are talking about post-COVID. We know in Guyana, we are not in post-COVID times. We are in, well, we're going to keep on having new normal times. So, and we really don't know what is the normal. So I thought maybe we could just look and see, tickle our minds, see if what could be the possible challenges that we have. So in terms of training, well, we do clinical on the job training, as well as the research. But what we found in terms of the clinical is that, well, you may have less patients. We've certainly been finding we have less patients during definitely during the surges coming into the hospital. So therefore into the clinics, because we weren't allowing the positive patients in. So you have less patients, than maybe in looking at it means your study population is going to be less, and we'd have to look at that. We might have been expecting certain numbers, and it may not be quite what we had thought. And then we actually have the patients who are COVID positive. Certainly at the hospital, we're no longer going to be seeing them. They're going to be at another institution. So they be lost. They would be persons who have had trauma and injury, as well as their positive status. So we've got to take those into account. And then even for those who are collecting data on the patients, it's risks that are now involved when you're dealing with the COVID positive patients. So, and we can't leave them out of the data we are collecting. So it's just thinking, well, how are we going to address those sort of issues? And then even in terms of the emergency, in terms of trauma, this initiative is dealing with trauma of the different types. So I got MVA there, motor vehicle accident. I've just learned that I'll put that motor vehicle crash or whatever. But anyhow, they're the different types. And maybe the numbers may change according to what's going on in the pandemic. Will less people come in because sometimes we've had curfews, or would more people come in because they're at home more, and so there's more violence. Don't know how this will impact in terms of our numbers. And then the mix of the types of injuries, whether it is from the traffic accidents or from self-harm and so on, would that change? I think in some places they saw less road traffic accidents because people were out less because of the curfew. And are we going to be seeing this sort of thing? So it really comes down to we have to look at our data and see if it is reflective of the normal in the end. And well, my base specialty is anesthesia, so I'd actually looked at the changes in numbers in terms of surgery and anesthesia. Let's see, just as an example, we could move. Apparently, this isn't moving. The next slide. Thanks. Just to bring it home, before COVID, we had in the blue is elective cases and the red is emergencies. Before COVID, we got 2019 BC. Before COVID, you could just see the difference. We had like 5,000 emergent electives and about half of that emergencies. And by 2020, in the end of that, much less. Okay, and the next slide. There wasn't much change in the emergencies, but we don't know whether a change in the types of emergencies that we're getting, as I referred to. But certainly our elective cases in blue there's been a marked drop. We know we are trying to get back, always trying to get back to normal. What we found at the hospital every time we tried to start to, let's say, do electives and get back to normal, well, things happen and we get a surge or there are changes. So all this what we need to take into account, I think, when we are getting our data. Then next slide. And in terms of the didactic or classroom, the training, well, we had stoppages, extensions to programs. I mean, you had internet challenges, which we're using Zoom and so on, but we know the vagaries of our internet. And so this might affect our deadlines when we're doing training of this sort. There's not endless. I think the initiative has a certain time frame. There's not an endless, deadline. So we have to be thinking about some of these issues. And then if we're going to be training people, we have to look at the numbers. If we're going to be doing large numbers, well, we have issues finding COVID compliant spaces, I call them, so we have with appropriate distancing and so on. So it's just be thinking about some of these issues. And in terms of research, you'll be looking to get data, and we find that sometimes we can't get the chart data in the medical records area because that space is limited. So it's not COVID compliant. So people have been trying to do research and get in there, and then they're on a long list of people who are trying to get in, because normally everybody can go in and sit in their corner, and now you can't, because we can't actually remove the charts. So all this can slow you down. It can get frustrating, yeah? But that's the realities of what we're living now. And then, as I mentioned, the data you're collecting might be colored by the COVID-affected patient numbers and the mix. And then we've been trying to get workshops, research workshops and conferences. We've postponed them, and all due to the vagaries of COVID. Let's set up to do a workshop, everything set up let's say in a week, but then there were travel issues, who got COVID, couldn't travel, etc., etc. And then we ourselves here with the responses from the government level, we've had to postpone conferences and so on. So there's that uncertainty that again affects deadlines. Next slide, please. That was it. Right. So just that's it. One more. Sorry. Can we go back? Yeah, there was one there. Sorry, you missed it. But basically, it was just to say that, just to wrap up, is that, well, so what should be our approach? I would just say that, well, in terms of the gathering the data, maybe we have to look more at perspective instead of retrospective studies. We tend to do a lot of retrospective. It's very valuable, but we may have to look in terms of that. And certainly there are the challenges, but I think once we are aware of the possible challenges and limitations in doing training and research in these times, I think we can work together to avoid or to at least address these issues. And I think, well, that the initiative is appropriately termed, the acronym is GRITT, and I think we have to have a lot of grit in order to be moving forward with this initiative. Thank you very much.
Well, thank you, Dr. Harvey. I think the way you ended it just made all of us smile. George, are you going to make a presentation? Sure. And the next speaker is Dr. George Musa from Colombia.
Thank you. I think everything that everyone has said so far is right on the money. No. One thing that I'd like to see is more, as I'm a medical geographer, I'd like to see more data in relation to space and location be able to be accessed not only by all of you, but by other researchers that may want to help. One of the challenges that we have had is being able to identify cases of anything, suicide attempts, but also cases of COVID and such. Everything's reportable at the regional level. Injuries may be eventually reported at the regional level or at the hospital level, but to be able to identify critical issues at the local, right, at the local village, I think is going to be critical for reducing injury-related deaths and harm.
Well, thank you, George. I must apologize. If we have any comments or questions from online, and then also those of you, if you want to make a comment, please let me know by raising your hand. I would like to apologize to by saying that George was from Colombia. With this project, everybody belongs to the Guyana Wellbeing, Mental Health and Wellbeing Project. So there's nobody from Colombia, there's nobody from Guyana. We are all one in the same boat. So George, my apologies. Any question, comments from the floor? Yes, ma'am. And indicate who you are and then also who you want to direct your question to, or to all the panelists.
Okay, thank you very much. This is a general question or a comment question to all the panelists. Jennifer Bentic, and my interest has been particularly spiked by what I've just heard. And so what I would like to know is, how do we move on? Sorry, I'm sorry. Yes. How do we as in we who have assembled here with you who are the panelists or coordinators, how do we move on? Would there be any input required from us? What guidance would be provided? And basically that is what I would like to know before I leave here.
Well, thank you. I think probably Christina might be the best person to answer this.
Try. So as I said earlier, we're having our first meeting this afternoon, and that is going to allow us to identify how we are going to structure this, how we are going to give people access to us. So we will have some of those answers this afternoon, and I think Professor Cummings' office will certainly be one of the places where people can find out how you can join us going forward. If you're asking specifically about the training program, that will become known. We're hoping to be able to implement the online training starting in January. But again, we will work out those details this afternoon. I apologize. As I said, we are just starting, and we definitely want to invite as many people into the process as possible. If I could ask you, from what sector are you coming, and is there a particular area that you're interested in joining us in some particular focus you have? Could I ask you that?
Thank you. Okay, my area, I should say, is particularly, it's sort of broad, but research, project management, public health, education. So pretty much in a nutshell, that is the areas I've been operating in and the experience or the contributions I could make to the process.
But which organization are you coming from?
At this point, more or less self-employed.
Thank you.
So I think the nutshell that you just described is exactly what we're going to be initially addressing. And I think some of the comments that were made here by Dr. Harvey and by Dr. Musa about their concerns are exactly the issues that we want to address, and we want to conduct the training in, and we want to start mentoring people in research projects addressing these areas. So for example, Dr. Musa talked about the need to be able to actually identify geographic areas where there might be a hotspot for car accidents or car crashes, excuse me. That's something that I know the university has a GIS expert, and it's, Dr. Musa is also a GIS expert. So as Dr. Musa is coming as part of GRITT, hopefully he will be joining together with the expert at the university, and we will begin to focus on these kind of areas regarding injury prevention and involve as many students as possible in that effort so that we can develop a greater expertise, interest, and awareness in these areas, how we can collectively move forward in prevention. Did you want to comment?
No, I just want to share something which I think is folkloric. I'm originally from the west coast of Berbice, and all my life, and this is for Dr. Musa, the medical geographer, as to how do we explain there's certain hotspots for accidents along the west coast of Berbice, right? Specific areas, and persons will tell you, for example, the Bari turn at one time call it the Dutchman turn, right? Because many persons died here, and there was a lot of folkloric, with respect to that. And so, and every year, at a particular point, accidents will occur. So how do we explain this as a medical geographer? Is this supernatural? Because that is what, from a folkloric standpoint, that is what, but really and truly, it has happened. They're really hot spots for accident, and persons for hundreds of years know exactly that these accidents will always happen on this spot.
Professor Cummings always meant to say crashes. Right, he meant to say that.
To answer your question, identifying the hotspots, identify that there's a problem. And then once we identify the problem, then we can take corrective actions. So it's very likely that there's a problem at the intersection that is not done right, that needs reworking by the road construction, the engineering and so on. And I would actually ask, was Dr. Aduku driving in those times that there was hotspots? Because we've known him to have a few of those. So,
thank you. I would like if Dr. Harvey is, of course, on the receiving end, getting all of these crash victims in the hospital. And one of the things that we're doing with GRITT is that we are working with the hospital, and we're trying to identify people who are actually coming into the emergency room who may in fact have been in the process of trying to commit suicide and having a crash. But I would also like to ask Professor Branas if he could speak to maybe an example of how this kind of challenge was dealt with in another training center, and how they were able to address it both academically and practically to bring about the change. So Professor Branas, could you speak to that?
Well, academically, The university is a great place because there are so many different sectors represented in the university. So it's sort of a great nexus to bring together groups who would otherwise be unconnected. And I put it in the chat. Injury prevention is especially interdisciplinary, and it's really important to imagine connecting seemingly unrelated actors and individuals and groups. So for instance, medical professionals and engineers is one good connection, legislators and public health professionals, city planners, geographers. So it's really, really important for success. So I'll give you a great example. So in Guatemala, we had worked with the Ministry of Health and made a first connection there with the Ministry of Justice, effectively, to look at homicide for the nation. And that was the first time that, surprisingly, all the homicide data was not held in the public health or the medical system in the country, it was held in the justice system. So by bringing the two together and doing exactly what Dr. Musa was suggesting, is doing a national hotspot mapping of homicides, some really important information was elucidated about where these were occurring and how resources could be distributed for the nation, and in particular in the neighborhoods around Guatemala City. So that's just one example of bringing these seemingly unrelated groups together, but you can imagine also the opportunities with motor vehicle crashes to be able to begin to impact those, and in fact, very much so for suicide, for you all to think about that as well.
We have one question from the net, and I would like to read that. And no, it's a comment. It says, oh, okay, all right, okay, okay, all right. Talking about Professor, comments, point about accidents or crashes. I'm told there is a point on the highway here called Conversation Tree. And since the time I was informed about Conversation Tree, I stay clear from Conversation Tree side. But that said, it appears anytime Christina and the others are here, I have one accident or one crash, and I've already had one. So please, whilst you are here, no more. Any final comments from our panelists? I'll start with Dr. Harvey.
Just to say that I'm very happy to be that this initiative is here, and that the Georgetown Public Hospital is part of this. And I think that we have a lot to offer, and that our partners, they have a lot to offer. So in that way, I think we're really on the right road. We have to put our heads together to now, to actually have the step-by-step plan. These are the early days, though, but I think that really we are on the right road, and I must say I'm very happy to be part of this. Thank you.
Thank you very much. I think one of our panelists said that HIV, TB, malaria, and of course TB and malaria, quite significant in our country. HIV will control to some extent, combine self-injury total worldwide, and that is something which is critical in the way we go forward. We spend millions of dollars trying to deal with HIV, malaria, and now COVID, all infectious diseases, which is, so we're having, I call this the triple burden. We used to speak about the double burden of chronic diseases and infectious diseases, even though injury can be considered chronic to some extent, it's grouped in, but they are the triple burden, I would want to call it. And so that alone signifies the importance, and the time to address it is now. And we are grateful for this initiative. And from a university standpoint, we will make the best shot at it, because indeed it will make a difference in the lives of people in this country. Thank you.
Thank you. I'm very excited to be here and be with the group here. I am not Guyanese, but I want to be Guyanese. I'm Dominican, so I'm pretty close anyway. So approved. Thank you. So I'm officially a Guyanese, at least a 0.25%, right? Quarter Guyanese. So I'm really looking forward to collaborating with UG, with the Georgetown Hospital, and everyone here. I'm very happy to be here. Thank you.
Professor Branas, if you have any parting words, over to you.
My only parting words is, well, first off, I just have to say, Dr. Harvey, I think the opportunity that Dr. Harvey is presenting some of the data at the Guyana Public Hospital is a wonderful first opportunity to learn some things. So, and then I'll just end by saying, I'm so sorry I can't be there in person with you, and that I did not mean to chide anyone about use of the word accident. It's simply a way of thinking, to really imagine that these are very preventable opportunities, particularly with good science and collaboration. So thank you very much. I'm honored to be able to be here today.
Well, thank you, Professor Branas. We are looking forward to having these meetings every year. So please put it on your calendar now, so that next time you cannot say, oh, well, I didn't hear it. So we're expecting to see you here, and trust me, maybe when you come and we have a new center, we want to create our own center here. When we have a new center, you may not want to go back to Colombia. I give the floor to Christina.
Well, again, thank you all for your interest, and I think it's very clear from the few members of our group who are here, Dr. Harvey, Dr. Cummings, Dr. Branas, Dr. Musa. You can see the level of expertise that we are trying to collectively bring to the table. There are other people who are not here, who have similar levels of expertise that are going to make this, I think, a very exciting and effective program. And as I said many times, that I see the challenge of reducing suicide as a very, very doable task. It's, you know, Guyana has such high rates of suicide. But as I showed yesterday, Guyana also has extremely high rates of crashes, violence, many of the things that we talked about today that we can go after collectively and bring those numbers down. I hope that when we look at these pyramids of tragic events causing loss of life, and we keep seeing Guyana as the worst, that in very short order, we're going to see it move up that pyramid and no longer be the worst. Hopefully it'll move to the top. That's a real challenge, but to get it off the bottom, we definitely can do it. We can do it together. And so I look forward to all of you joining me. I thank all my colleagues for the work that they have already put in to securing the funds to do this. And now we got to do the hard work of making something happen. And again, I welcome you and everyone at the university and at the Columbia Center to come together and let's make this happen. Thank you all very much for being here. Look forward to working with you. Thank you.
Well, thank you all. Those of you who have been able to make it in person, thank you. And those who are online, would like to thank you. Please remember that we continue tomorrow with some very interesting topics. Please note the lived experience and the role of carers and survivors. This is very important. Please try to be here. Environmental approach to suicide prevention. Please try to be here. Clinical training, assessment, and management of anxiety disorders. That's a very good topic. Please try to be here. And all these that I've mentioned, two of them have, well, three have CME credits. So please make sure that you are here, either online or in person. Community interventions and decriminalization of suicide. We know that's thematic for our country, and it's something Minister talked about. So please be here to discuss it with us. Risk factors, knowledge, attitudes, and practices of type 2 diabetes patients in Guyana. So on that note, I'd like to wish all of you a good afternoon, a good lunch. Unfortunately, our program here in Guyana doesn't have money. So I didn't cater for lunch. But I would like to wish you well. I'm hoping that in future, when the government gives us some money, we will have all that done. So have a good afternoon.